Hi, everyone. Thanks for being here. I'm just going to wait while the room count goes up. It takes just a minute or so for everybody to get in the room, and I don't want anyone to miss anything. We're really excited about the presentation tonight. I want to welcome you all to Building a Pain Management Pyramid for Pets with Dr. Robin Downing. I'm Christy Keith, Senior Communications Strategist for Fear Free. Before I introduce our speaker, I'd like to take care of just a few housekeeping items and frequently asked questions. First, we'd like to thank our friends and Fear Free sponsors at Vetiquinol for making this webinar possible. We'd also like to thank all of you for taking time out of your schedules to join us here. I know that with so many different time zones being represented, that it's sometimes really hard to attend webinars, and we're so grateful that you were able to join us. And yes, CE is available for this webinar in places where race CE applies. But it is only available for those of you who are here for the live presentation. If you are watching the recording of this webinar, there is no CE available, and we're sorry for that, and hopefully that's something that will happen more in the future for our recorded webinars, but for the moment it's not. For those of you who are here live, I'll be sending an email out immediately after the presentation. In that email is a link to the survey that you need to take in order to get your CE. If you registered with an email that you don't frequently check or think you might have typoed it, for example, if you did not receive a confirmation email, then please be on the lookout for it. If you don't get it, email me right away. Email me tomorrow or even tonight at fearfreepets@gmail.com. Please don't use the regular office email, because that email I just gave you will come straight to me and I will take care of it right away. If you email the office at the WAG's email address, it's not going to get to me until tomorrow. And the CE survey is only open until Friday, so please, do attend to that right away if you want to get CE. When you do take that survey, the final question is a link to download your CE certificate that you can then print and fill in with your name. However, if you don't provide accurate contact information in the CE, and if you don't complete the survey, RACE won't process your credit. So make sure that it's complete and everything is correct so that you will actually receive the credit. The certificate itself doesn't really mean anything if RACE doesn't have a record of you completing the course, the webinar in this case. So anyway, I apologize for all the cautionary stuff there, but we just wanted to make sure that you got the CE that you're entitled to. And as I mentioned, there will be a recorded version of this webinar. It will be available within around 1 week of tonight at fearfreepets.com/webinars. So you can just go right there and look at it, or share that if you want to share this with one of your colleagues. The final little bit of housekeeping: if you have questions for Dr. Downing at any time during the webinar, please submit them using the Q&A interface. We'll get to as many as we can at the end of the presentation, but please try to get them to us as they come to you. Don't hoard them. Hoarding is bad. It's much easier for us to get them processed in a queue to be answered if we have them, rather than getting them all at the end, which unfortunately means that most of the latecomers aren't going to be answered. So please send them in as soon as they come to you. If by chance she answers your question later in the presentation, I'll just discard your question. Okay, so all of that aside, it's now my pleasure to introduce Dr. Robin Downing. Dr. Downing is a diplomate of the American College of Veterinary Sports Medicine and Rehabilitation, a certified veterinary pain practitioner, and was the 3rd veterinarian in the world to earn the diplomate credential in the American Academy of Pain Management, which is a human pain management organization. She was a founder of the International Veterinary Academy of Pain Management and served as that organization's 2nd president. In addition, she has served as president of the American Association of Human-Animal Bond Veterinarians, which is now the Human-Animal Bond Association. She's hospital director of the Downing Center for Animal Pain Management and has received many regional, national, and international awards, including the Excellence in Veterinary Medicine Award in 2001 from the World Small Animal Veterinary Association. She's an internationally sought after speaker on a wide variety of topics, including pain management, physical rehabilitation, physical medicine, hospice and end-of-life care, anesthesia-related topics, and overcoming compliance obstacles and issues in veterinary medicine. And because that's just not enough, in 2016, she completed her Master of Science degree in clinical bioethics from the, and I'm sorry, I don't actually know how to pronounce this, Robin Icahn.
The Icahn School of Medicine
at Mount Sinai in New York City, and Union Graduate College, with the intention of translating the practices of clinical bioethics for application in veterinary medicine. This commitment includes framing the imperatives of the fear-free movement, as well as comprehensive acute and chronic pain management as obligations grounded in bioethical principles. In September of this year, because again, that just wasn't enough, she will begin a doctorate in clinical bioethics at Loyola University of Chicago. Now that my personal self-esteem is completely in the basement, thank you for being with us tonight, Dr. Downing. Please take it away.
Thank you, Christy. Thank you so much. And thank you all for taking time out of a busy week, particularly following a holiday weekend, to join me this evening so I can talk about building a pain management pyramid for pets. I'm a visual person, and so for me, when I talk about building a pain plan, I have to think about it in terms of some structure. And for me, a pyramid really gives me the image that I'm most interested in. I'm particularly proud of the fact that both my primary care practice, the Windsor Veterinary Clinic, and my pain management referral specialty practice, the Downing Center, were the first practices in the state of Colorado to be certified as fear-free practices, in addition to our team members being fear-free certified professionals. This has really been a game changer in our practice, and any of you who are logged on this evening are certainly reaping the benefits and experiencing that transformative change for yourselves in your practices and among your practice team members. Before I get started, of course, I want to make a big thank you to Vettakino as a sponsor of this particular program, and to the Fear-Free organization as a partner sponsor in making this educational opportunity available to so many people, and for archiving it so that many other people will have access to it as well. So at the Downing Center for Animal Pain Management, our practice motto is this: that they, our patients, don't deserve to hurt. And as my first degree was in English, so I actually accumulate sayings from old dead guys. One of my favorite old dead guy sayings is this one: Divinum est opus sedare dolorum. Galen was actually acknowledged to be the first physician, even predating Hippocrates. And these words mean that divine is the work to subdue pain. And I absolutely believe that that is, in fact, our obligation to provide this divine work. So the first question that I'm often asked is, so why is pain important? It may seem self-evident, but I think it's important to tease out just why is pain such a critical issue? Well, first of all, it's very complex, and that makes it scientifically intriguing. It's clinically challenging, both in an acute and chronic pain setting, particularly challenging to us who deal with nonverbal species. That makes pain easy to overlook because our patients don't speak to us in a language that we easily understand. And one of the reasons that pain is important is that when we make a decision as professionals to change or improve our way of managing pain, it means that we have to make changes. And human beings really don't like to make changes. We really would rather mistake the edge of our rut for the vastness of the horizon. There's a reason that humans and dogs get along so well. We like routine, we like the same. And making change is hard. But improving pain management does mean making change. So building a pyramid, how do we do that? Well, we have to begin at the beginning. And that means that we want to do a thorough examination. And don't let this list intimidate you. When I talk about doing a neurologic exam and a soft tissue palpation and joint range of motion and gait assessment, what I'm really talking about is for us to use our eyes and our hands, those tools that we were trained to use when we were in veterinary school or in veterinary technician training programs. These are the tools we have to interface with our patients. We also want to make certain that we don't miss important comorbidities. So we want to make sure we include a good metabolic profile. And we want to make sure that we don't forget radiographs when they are indicated. And I will be the first to admit that I do not radiograph every single painful patient I see at the first visit. But once their pain is under control and it's reasonable for me to include a radiograph, I will do it. We want to make sure that we don't mistake a patient who has an osteosarcoma as a patient who has osteoarthritis. I've had 2 of those kinds of patients present to my specialty practice. We also want to make sure that we identify all the things that are going on so that we can treat all of the treatable issues, make a plan, and work the plan in partnership with the client. We know that chronic pain is best addressed from a multimodal approach. And that doesn't mean that we have 3 NSAIDs on our shelf and call our treatment multimodal. It means that we recognize that it's no longer appropriate just to stop with a non-steroidal anti-inflammatory drug. We want to make sure that we break that chronic pain cycle as quickly and effectively as possible before we initiate any kind of physical medicine or tissue manipulation. It also means that we have to get real about multitasking, because we are going to have multiple things going on in the body. So it's important for us to be watching for multiple results that are coming from the multiple tools we leverage. I like to think of this as my juggling act, and my treatment is really about balance and creating balance among the various pain management strategies that I put into place. Once again, it's a good reminder that the client absolutely is an essential partner, or any plan we make will fail if we are not partnered with that client and they do not understand not just what must be done, but why whatever it is we are prescribing must be done. Then we will fail miserably and the pet will continue to suffer unnecessarily. One of the things I like to do when I give a talk like this is just provide a gentle reminder of how to do a pain management palpation. For those of you who are interested, I actually had an article published in Clinician's Brief. If you Google chronic pain management in dogs and my name Downing, it will come up as a Clinician's Brief open article. And in that article, I had a sidebar of how to actually conduct a pain management soft tissue palpation. And this was the first formal description in a refereed article of how to do it. Well, for tonight's purposes, I have my lovely feline assistant that you can see here who's going to help you know how to do pain management palpation. So here's how I conduct it. And it really doesn't matter how you conduct your pain management palpation. It only matters that you do it the same way every time on every single patient, no matter how big, no matter how small, no matter how young, no matter how old. This is the same strategy that we all learned when we were learning how to auscultate a heart to listen for a heart murmur. The way that we learned how to recognize an abnormal heart sound was by listening to many, many, many normal hearts. And the same is true of a pain palpation. If we palpate every pet that we see in the same way, systematically, what will happen is our hands and our eyes and our bodies will learn what is a painful response, because our bodies will also learn what is a normal response. So our goal here is that, as you can see, I have my hands at about a 45-degree angle off horizontal, but I want you to notice that the vector of my palpation is not that 45 degrees. It's actually straight up and down into the paraspinal muscles. So the first part of my palpation goes from the base of the skull to the base of the tail along the paraspinal muscles. I keep my hands at about a 45-degree angle, and I'm palpating with the fleshy part of P3. I'm not palpating with the ends of my digits. If you palpate straight down with the end of your digits, you will actually induce a painful response, and that can give you a false positive. Rather, what you're after is using the fleshy part of P3 and palpating straight down into those paraspinals. This will just give you another view of that. Notice that I'm using 2 fingers. On a really big dog, I will often have 3 fingers employed. In a really tiny cat, I'm actually only going to have room for 1 finger on those paraspinal muscles. I will palpate all the way to the end of the body, and please don't forget the base of the tail. One of the places that we sometimes are deceived into just ignoring is that place where the pelvis and the tail come together. And in particular, cats will often have pain in this area from early osteoarthritis at the base of their spine. Then what I do is I go back to just behind the shoulder blade, then I'll go to the place where the rib cage ends and the lower back begins. And I'll do this also at the lumbosacral junction, where you'll see me have my hands at 10 and 2, like the hands of the clock, 3 and 9, like the hands of the clock, and 4 and 8, like the hands of the clock. And what I am doing in these 3 palpations is I am actually at the very edge of the paraspinals when I'm at 2 and 10. I'm in the lateral lumbar muscles, or if I'm up on the torso, I'm in the latissimus dorsi muscles at 3 and 9. And when I come in from this angle, as you see underneath the paraspinals, I'm actually in the lumbosacral area. In that lumbar area, I'm palpating the iliopsoas muscles. When I'm up on the torso, I'm actually palpating the pectoral muscles. What I want to do is show you a cutaway of where that iliopsoas muscle lives. So if you look toward the top of this anatomy structure, and you can see the vertebral body, and you can see that the dorsal muscles of the paraspinal muscles are there. You can see the lateral lumbar muscles at 3 and 9. And then you'll see 2 muscles outlined by green and orange. And those 2 muscles are the iliopsoas muscle bundle. So you can see that we're actually appreciating them rather than actually touching them. The reason I bring the iliopsoas muscles to your attention is that we're taught about these muscles when we're freshmen in veterinary school, and we go through anatomy and we dissect an animal and we find those muscles on our dissection specimen, and then we promptly forget about them. Well, these muscles are very, very important when it comes to nonspecific back pain in dogs and cats, because when an animal begins to have osteoarthritic changes in the spine or in the low back or in the hips or in the rear legs, they actually change their biomechanics, and the iliopsoas will become hypertonic. And when it is hypertonic, it becomes hypersensitive. And this can be actually an important source of pain, chronic pain, in our patients. I include this slide just to remind us all never to lose sight of the fact that animals can and do have maxillofacial pain, and it's important for us to look at their heads and lift the lip and look for oral pain that could be contributing to a chronic pain scenario. So back to building this pyramid. One of the things that's so critical for us to come to grips with is understanding that most of our chronically painful patients are less active. And as a consequence of being less active, they are often overweight. And my good friend, Dr. Denny Marcellin Little, who is now at Davis, has done a great job of articulating that the most important physiotherapy technique we can apply for our chronically painful patients who are also overweight is normalizing their body composition. Now, it's really important to me that you pick up on the fact that I did not say they need to lose weight or we need to make them thin. What we're really talking about doing here is normalizing their body composition. So I'm not interested in taking a fat marshmallow dog and making them into a smaller marshmallow dog. What I'm interested in doing is helping them burn their fat compartment as their energy source selectively and allowing them to preserve or even build muscle so that we're actually changing the composition of their body. If we're going to do this, it's critically important that we choose a nutritional product that has been proven to actually do what we need it to do. Proven to facilitate that loss of excess fat, proven to upregulate the genes responsible for lean body composition, proven to downregulate the genes responsible for an obese body composition. And this manipulation of genes on the DNA, which is not about changing the DNA, is only about upregulating appropriate genes and downregulating inappropriate genes. This is the science called nutrigenomics, or utilizing nutritional complements and nutritional profiles to actually change genetic expression on the DNA. It's important that we make a long-term nutritional plan right at the beginning. And why is this important? Well, it's important in our chronic pain patients because some of them have comorbidities. Some of them have more than one thing going on at a time. And it's important for us as the medical people in the equation to utilize our skills to make a nutritional plan that is going to address whatever comorbidity needs to be addressed in the long term. So we may make a two-staged nutritional recommendation. Stage 1, normalize body composition. Stage 2, deal with the comorbidity with an appropriate nutrient profile. And it's also important for us to understand and to communicate to our clients that when we utilize therapeutic nutrition, that this is best achieved when we have a fixed formulation, which means every single batch is the same as the batch before and the batch after, and that we have consistency of feeding. Clients really do have the ability to understand the concept of nutrigenomics. Clients really do have the sophistication to understand and appreciate that we can use food as medicine, and they really do crave the opportunity to understand why we make the recommendations we make. So once we have that piece in the foundation of our pain management pyramid, now we take the next step, which is to break the pain cycle. And I want to talk first about breaking the pain cycle pharmacologically before we move on to thinking about breaking that pain cycle in other ways that complement the pharmacology. So the NSAIDs really do remain our first strike. They're a very, very useful tool, particularly in the face of inflammation, which of course we know is often present in that disease we call osteoarthritis. They decrease inflammation and they decrease pain, not just by decreasing the inflammation, but by acting at multiple locations. So it's important for us to be reminded that we used to think nonsteroidals only worked at the site of inflammation. So if we have a joint with osteoarthritis, then the NSAID works at that joint, and that's the only place it works. And what we need to remember is that there are actual receptors in the central nervous system that help that nonsteroidal work to decrease the pain experience, not just by acting at the site of inflammation. It's also important that we come to grips with the fact that there's no one best NSAID. No matter what kind of marketing materials we might be exposed to, there's no one best NSAID. All the NSAIDs work very effectively. All of them have a very similar safety profile. And it is true that some animals will do better on one nonsteroidal than a different nonsteroidal. That's true in people too. It's also important to help our clients know that we can't mix and match nonsteroidals. So you can't take meloxicam on Monday and ferrcoxib on Tuesday and carprofen on Wednesday. Not a good choice. What I have found now in over 20 years of working with painful patients of all kinds, of all ages, of all sizes, and where their pain is generated by multiple morbidities, what I have discovered is that a failure or a sensitivity to one nonsteroidal anti-inflammatory drug does not necessarily mean it's a no for all nonsteroidal anti-inflammatory drugs. What I also have found, however, is that if I have a patient who has an adverse event to one nonsteroidal, and I change them to a different nonsteroidal, and they have a second adverse event, I will not push it with a third. I do know practitioners who will talk about going to a third nonsteroidal, but I can tell you that earlier in my career when I did that, what I found was the third didn't work any better for those individuals than the first two. Once pain is under control, then we can think about titrating the nonsteroidal dose to the lowest effective dose. Now, I need to qualify this. This is a very important point. Back in the battle days, veterinarians used to talk about, well, I'll start them out on a full dose of a nonsteroidal, and once they're feeling good, I'm going to give them a smaller dose, or I'm only going to dose every other day. And our colleague, Dr. Duncan Lascelles at North Carolina State University, did a really elegant study asking the question, can we truly titrate the dose of a nonsteroidal down to a lowest effective dose without compromising the patient's comfort? And the answer was no, we can't. He did a study that utilized force plane analysis as well as palpation and observation. And the answer was no, we can't. And my qualification is we cannot if a nonsteroidal is our only therapy. That's the part that really needs emphasis. And what Dr. Lascelles did was he looked at nonsteroidals as a monotherapy and asked the question, if nonsteroidals are a monotherapy, can we titrate to a low dose? And the answer is no, we can't. But if we have a truly multimodal plan in place, then we can titrate that nonsteroidal dose to the lowest effective dose. And in fact, in my practice, many of my patients, their lowest dose of nonsteroidal is actually 0 once we have these other pieces in place. And this is just one example of the many nonsteroidals that we have available to us to put into that foundation of our pain management pyramid. And I just have to wonder how some dogs are willing to put up with this. All right. So what's another pharmacologic tool we can use to break the pain cycle? Well, what we have to remember is that chronic pain that's been present for a long time is generally actually maladaptive pain, according to Clifford Wolf, who is a physician who has been dedicating his career to chronic pain and to specifically maladaptive pain for most of his long career. Or we could call it maldynic pain. Dr. James Giordano is a pain researcher who was the investigator who linked serotonin pathways with chronic maladaptive pain. Maladaptive pain is a actual miseducation or maleducation of the central nervous system, where the central nervous system actually facilitates the pain experience. And when we deal with maladaptive pain, that means that we have to target the dorsal horn of the spinal cord, where pain modulation actually happens. Making a target of our therapy is actually a really new concept in human pain management, and it's exceptionally new in veterinary medicine. And the target we are after is in the dorsal horn. The weapon we need to hit that target is a drug called gabapentin. And while I always hesitate to think of a single therapy as the latest and greatest or the very best, I will tell you that gabapentin in my hands is very nearly a silver bullet for chronic maladaptive pain. It has a very, very elegant and specific place that it works on the alpha-2 delta subunit of the calcium channel in the dorsal horn. And what it does is it modulates calcium influx and efflux from the neurons in the dorsal horn. And by doing that, it actually changes the threshold for firing for those neurons in the dorsal horn. And in human medicine, it is one of several gold standards for managing chronic maladaptive pain. Interestingly enough, in humans, there have been a couple of studies looking at gabapentin in the perioperative period. And what I have found is in my acute perioperative period for my patients who have really big pain, like multiple tooth extraction or orthopedic procedures, gabapentin plays a very important role in those patients during the first 2 to 4 weeks following their surgeries. and managing their acute pain. It has to be dosed appropriately. And this is where our literature really fails, because in our literature, you will find references like 1 to 2 milligrams per kilogram per day. And my response to that is you might as well pee in their left ear, because you will get about as much effect from that. In my practice, and when I teach about gabapentin, I articulate to colleagues that we need to start at 5 to 10 milligrams per kilogram, 2 to 3 times a day. And that's a starting dose. I had one patient who had a spinal cord sever in he was run over by a car. It severed his spinal cord. He was completely paralyzed in the rear limbs, and he developed phantom limb phenomenon and ate the toes off his back feet. And the dose of gabapentin that prevented him from having that phantom pain experience was 200 milligrams per kilogram of body weight 3 times a day. So you can do the math. That's an awful lot of gabapentin. We didn't start there, but that's ultimately what we needed. Gabapentin has to be dosed to effect, and that effect is the relief of pain. Now, one of the side effects for gabapentin when we first start using it is the potential for sedation. And so in order not to freak out my clients, I generally start with whatever dose I've calculated once a day in the PM for 3 to 4 days, because if they're going to get a little sedated, they're going to bed shortly after they get their gabapentin. And then I will go ahead and escalate to twice a day. One of the myths of gabapentin is that it isn't effective for a week to 10 days. And that's a myth. It actually provides activity quite quickly, but it takes 7, 10, 14 days to reach a steady state of activity. So I don't even do a recheck in these patients until they're out 2 to 3 weeks before I make a decision to escalate my dose of gabapentin. Sedation is really the only relevant side effect. And if I encounter sedation, I don't stop the medicine. I actually just reduce the dose to the next lowest dose. And long-term dosing is fine. This is not a drug that has an adverse effect on either the kidneys or the liver. And my take-home message is we need to dose it to effect. What is the effect? The effect is getting that patient comfortable. Whatever you do, educate your clients that they cannot stop this drug abruptly. If they stop gabapentin abruptly, the animal will have an experience called rebound pain, where they will become excruciatingly painful in a very short period of time. And often that pain is worse than what we started with. Only twice have I witnessed this, and this was early in my use of gabapentin, and it was a very, very hard lesson for me to learn because those animals suffered so unnecessarily at my behest. Another tool we can use pharmacologically to manage pain is amantadine. Amantadine is an NMDA receptor antagonist, so it works in the dorsal horn. It works in a different place from gabapentin, so it complements the nonsteroidals and gabapentin. According to investigators who published in the Journal of the American College of Veterinary Internal Medicine, the dose that they landed on was 2 to 5 milligrams per kilogram per day. The investigation was only done in dogs, and that paper reflected a study where it was only a nonsteroidal and amantadine, not gabapentin. In my practice, I have actually used it to complement gabapentin to very good effect. It is very well tolerated long-term. The JACVIM article talked about using it for 3 weeks and then discontinuing it. And if the animal had a relapse, to go ahead and do another 3 weeks. My experience with my chronically painful patients is that if they are very painful, that often they will do better if I simply have them use amantadine long-term. Now, amantadine was gone for a while, and then it was brought back in after the molecule was purchased by a venture capitalist. And so when it came back into the marketplace, it came back at an outrageously expensive price point. So honestly, I just guide all of my colleagues, don't even think about scripting out amantadine at 100 milligram capsule strength, which is what you can find in human pharmacies. Go to your compounding pharmacies and have it compounded for your clients. It's going to be much more affordable for them, because this is what we want. We want our patients to be able to do this kind of yoga. One more tool that I use that's a pharmacology tool is Adequin, and there is nothing other than Adequin. The polysulfated glycosamine glycans really are unique to this compound, Adequin, and it's useful for cartilage support in both dogs and cats. Please recognize that what I'm about to talk about is extra label use. It has never been labeled for cats. There's never going to be enough money in the universe for any pharma company to want to go back to the drawing board and do a study in cats. So we have to rely on, we just have to rely on our clinical experience and clinical publication. We do, in my practice, give the injection sub-Q and not IM, which means I teach my clients to dose this at home. And the dosing is actually what's on the label, 2 milligrams per pound, and I use it under the skin 2 times a week for 4 weeks, and then once a week for 4 weeks. And then we use it every 10 to 15 days for maintenance, so every 2 to 3 times a month. Now, if you read the FDA label, this is why I say it's extra label, it says give it IM, give it only to dogs, and you can only use it for 8 weeks. Well, we don't cure osteoarthritis in 8 weeks, so that never made any sense at all. And I have a lot of patients who take it every 10 days instead of every 15, because by day 13, the client can notice a difference in how that animal gets around. I try to start using this as early as possible because what Adequin does is it helps heal microfractures in the cartilage. It helps increase viscosity of joint fluid. And by doing those things, it actually helps the cartilage indulge itself in a phenom called imbibition, which is how cartilage actually sucks in nutrients. Imbibition is that function where in weight bearing, the moisture is squished out of the cartilage. And when we're non-weight bearing, that moisture and all of those nutrients are sucked back into the cartilage, much like a sponge. And Adequin really facilitates that process. So what about working on the pain cycle from a non-pharmacology perspective? Well, we have lots of options from both a nutrition and nutraceutical perspective. Nutraceuticals, remember, are nutritional compounds that act like a drug, but they're not really a drug. So if we're going to follow the evidence, which as veterinary professionals, we have an obligation to follow the evidence. At the moment, the best evidence for a nutritional compound with joint support technology is Prescription Diet JD. And we can also look to glucosamine, low molecular weight chondroitin, and ASU, avocado and soybean unsponifiable combination. That is in a compound unique to a product named Disassembling. We'd also look at omega-3 fatty acids. Now, if we're going to use omega-3 fatty acids, it's important to know that we do now understand what is a therapeutic dose. And the dosing range that came out of the data that was generated in the development of Prescription Diet JD for dogs was a range of 50 to 100 milligrams of EPA per kilogram per day total divided. And one of the things we need to understand about omega-3s is we have to have bioavailability in addition to having a therapeutic dose. Bioavailability means using a triglyceride form. If you go to your local GNC or you go to the grocery store or Sam's or Costco and you pick up fish oil, it will most often be in an esterized form, which is cheaper to produce. But it's not bioavailable. So it goes in one end and it comes out the other end unchanged. That triglyceride form is very, very critical. What we do in our practice is calculate the total EPA that we need, knowing that DHA is a part of all of the omega-3 compounds that are out there. I generally come right down in the middle of the dose, so 75 milligrams per kilogram per day of EPA. Then I subtract from that EPA what I'm getting from food. And in Hill's Prescription Diet JD Canine, there's 450 milligrams of EPA in each cup of JD. So if they're not eating Prescription Diet JD, then I use that total as my total to achieve a therapeutic dose. And that will mean that I'm going to choose a supplement. There are several supplements that are available now as a triglyceride form. Nutramax makes one, Nordic Naturals has a third, and then of course Betaquinol has their triglyceride omega as well. I will tell you that you will get therapeutic dosing more easily achieved using a liquid, because when we start to talk about a therapeutic dose, the dose is high enough that using capsules often becomes unsustainable and unaffordable. Other things that we can reach for include a compound called UC2, and this is an undenatured type 2 collagen, so much easier to say UC2 than undenatured type 2 collagen. UC2 is a fairly unique compound because it actually works by immune modulation in the GI tract to activate T regulatory cells. One of the things that really got my attention about UC2 is that some of the research revealed that it actually yields a positive result in humans who have both osteoarthritis as well as rheumatoid arthritis. And I don't know how many of you are familiar with either personally familiar with rheumatoid arthritis or familiar with people who are, their pain and joint destruction is absolutely unimaginable. And it is such a very difficult disease to manage, often relying on drugs that have really horrific side effects. So if we could leverage the immune system to help us modulate the pain experience, this is a great way to do it. This is called oral tolerance. And what happens is that the body is exposed to these small amounts of UC2 in the Peyer's patches in the GI tract. And this stimulates the immune system to actually secrete anti-inflammatory cytokines. And that suppresses the cells that are busy breaking down cartilage in the joints that have osteoarthritis. So UC2 is not a standalone, but it certainly complements the other tools that we have in our pain toolbox by coming at the pain and inflammation of osteoarthritis from a completely different perspective. And the other thing that I find unique about UC2 for my canine and feline patients is that the dose is the same for dogs and cats. Doesn't matter what size they are. We can also use a milk protein from hyperimmunized cows. The milk protein is called microlactin, and it has anti-inflammatory effects that we've actually known about milk having the potential to have anti-inflammatory effects for generations. But what this particular protein does is it inhibits cytokines, which in turn prevent neutrophils from migrating to sites of inflammation like osteoarthritic joints. And it also helps to actually modify the upregulation of the genes responsible for inflammation, and that helps us decrease the destruction of chronic inflammation. This is a different mechanism than a non-steroidal or than a steroid. And it's important to understand it's a different mechanism, which means we can use it alongside a non-steroidal or a steroid. It takes time to achieve peak effects. And that's why we can't use microlactin, that molecule, for acute pain postoperatively, because it does take about 10 days to reach a steady state. So we can see some initial effects within 5 to 7 days, but I create the expectation of my clients that we won't see steady state effects until we get out about 2 weeks. And what I do is I overlap my use of microlactin with other modalities, specifically with non-steroidals. And once I establish that I've got good pain relief in place, then I'll begin titrating down that dose of non-steroidal or corticosteroid if I'm dealing with an animal with an immune-mediated issue. The molecule microlactin is in a product called duralactin that's manufactured by PRN. There are very, very few side effects reported, and in my practice, where I have hundreds and hundreds of patients, both cats and dogs who've used the microlactin molecule, I've only had a handful of animals that were intolerant of it, and it was all GI. It just was, they were intolerant of it from a GI perspective, and it caused them to vomit. There are other non-pharmacology tools we can use, and I lump them together as physical medicine modalities and physiotherapy techniques. So don't forget simple things like heat and cold, or therapeutic laser, which now we understand we need to call photobiomodulation. We've also got electrical modalities to stimulate muscles. And therapeutic ultrasound, not so much in use in veterinary medicine as human medicine because of need to shave animals to have their skin be naked before we apply it. But tissue mobilization certainly is an amazing way for us to help restore mobility in our patients. We can use acupuncture and myofascial trigger point release. And we have other manual therapies like chiropractic techniques or osteopathic manipulations. And then, of course, the hydrotherapies, both swimming and working in an underwater treadmill. Don't forget about other simple things like assistive devices that we can actually send home to have clients use at home to make the at-home time just as comfortable as it can be. I think that we as veterinarians are too slow in applying our knowledge to encourage our clients to use wheelchairs. We think of wheelchairs for animals that are completely paralyzed, but I'm going to show you a picture of a patient who developed degenerative myelopathy, and her wheelchair was leveraged long before she lost her ability to walk, and what it did was actually assist her in walking. There are also some really excellent slings out there that are available to us. The two that come to mind, one is called Ginger Lead. The other is a sling that is available from a company called Four Flags Over Aspen. And then we have supported vests. The Roughwear company makes some great vests that are supported for animals to get assistance at home or during their physical therapy workouts at my practice. Help 'em Up Harness is another brand that is excellent. And then don't forget about dogs that really want to participate, but they really just can't walk at all anymore. And don't be bashful about encouraging your clients to get rolling carts or rolling wagons for those animals. So as promised, this is Chomo, and Chomo developed at 13 symptoms consistent with degenerative myelopathy. So she became paretic in both of her rear limbs. She had decreased CP. She was not a painful patient, but she was profoundly weak. We got her a wheelchair, and I want you to notice that her feet are actually upright on the floor. This was early in her use of her wheelchair, so she was still able to use her rear legs. She just couldn't support herself. Within 1 week of having her wheelchair, she actually went back to running 3 miles a day with her client, with her family, with her owner. After a period of multiple months, her paresis progressed, and we had to change the angle of the axle that you see on the rear part of her wheelchair. We had to actually lift it so that her feet were off the ground, and we used slings to help her feet from not scraping on the sidewalk. But Chomo used her wheelchair from that point when she was 13 until she actually needed to go to heaven at the age of 16 as a result of end-stage chronic renal disease. She ended up with acute on chronic renal failure and needed to be euthanized. Her wheelchair, actually, they ended up getting a second set of wheels because she actually wore them out. So don't be bashful about recommending assistive devices like this. This is actually from Canine Carts West up in Bothell, Washington. So what about other non-pharmacologic strategies? Once again, I think that we as veterinarians, we're a little slow to think about how we can modify the home environment and home activities. Everyone has a video cam on their phone, and we need to have our clients show us, what does your house look like? What do your dogs and cats do when they're playing? One of the simplest things we can do is simply raise the food and water dishes to elbow height, so their spine is in a neutral position. They're not having to bend over and touch their toes to eat. We can cover slippery surfaces. I will tell you that I no longer recommend area rugs. Instead, what I recommend are the interdigitating foam squares that you can get at Costco and Sam's in the school supply section. They're brightly colored on one side with the little diamonds for households that are doing daycare. The back side is gray, not very sexy or exciting to look at, but it's a great surface for animals that are losing the ability to keep their feet under them on a slippery floor. It's important that we let our clients know we should modify access to stairs. Baby gates are a great invention, and we should be teaching animals how to go up and down a ramp to get into and out of a vehicle, and we should teach them that when they are young, so that when they are old, it is not a novel experience. We may have to actually modify play with other pets, and this is where having video of the animals interacting at home can be critical. Don't forget to give your clients homework. Be as specific as possible about that homework and write everything down. I encourage my clients to keep an activities of daily living diary. In the human medical world, they call this ADLs. And we want to know what are the animals' activities of daily living so that we can help the client have realistic expectations about what we're going to be able to restore, what we are not going to be able to restore, and what are we going to need to adapt, and how can we adapt their lifestyle. I like to include diagrams whenever I can, or photos whenever I can. When I prescribe therapeutic exercises for my clients, I actually have handouts that have pictures of animals doing those therapeutic exercises. Be very specific about how many reps you want of those exercises, how many sets you want the client to accomplish in a session, and how many sessions in a day. Be in dialogue with the client so you know what's realistic for them. And then clarify any building of endurance or activities. It's really important if I've got an animal that is recovering from an orthopedic injury, for instance, and they have osteoarthritis present, and they've had a period of rest, that we don't go straight back to the activity they had before they got injured. So, it's a fear-free sponsored talk. I got to talk about pain and fear because they are absolutely intimately related. So are we talking about pain or fear or anxiety or stress or distress? Well, I will tell you that while we know that animals cannot and do not anticipate or fear death, they certainly can and do anticipate and fear pain, and they will try to avoid it at all costs. It's also very important to understand that research is absolutely clear on this. Pain amplifies fear, and fear amplifies the pain experience. And this becomes a self-perpetuating cycle. And it doesn't matter where that pain is coming from. IBD, it might be osteoarthritis, might be periodontal disease, might be neuropathic pain, might be a dermatopathy, could be an acute injury, could be postoperative. It does not matter. Pain amplifies fear, and fear amplifies pain. We know that fear, anxiety, and stress will escalate more quickly and is amplified in painful patients. So in these patients, you really need to consider PVPs or pre-visit pharmaceuticals. And here's the thing. We have such a large toolbox of potential PVPs for us to use. What I'm going to do is just narrow this down and let you know that in my practice for cats, I use gabapentin, 100 to 200 milligrams per cat, 1 to 2 hours before the appointment. In dogs, I really tend to reach for trazodone in that 5 to 8 milligram per kilogram range. It's critical it be given 2 to 3 hours before the appointment in order to have maximal effect. What is interesting about gabapentin and trazodone is this. If you have a patient who has chronic maladaptive pain, these drugs will not interfere with your ability to diagnose that pain. Dissociative agents will. So it's very, very important that we not use drugs that will actually inhibit our ability to detect pain that's present and to understand where that pain is. FAS definitely does interfere with pain detection and diagnosis. And so that's why it's critical for us to reach for PVPs when they are appropriate. FAS also interferes with ongoing reassessment of painful patients. So please think about this as an animal that is anticipating and fearing pain. They want to avoid it at all costs. They know that being touched by a human is torture. I don't want to be touched by a human. They will do everything they can not to be touched by a human, and that escalates them into this horrible state of FAS. If we interrupt that cycle, that gives us a chance to understand that the animal is in fact painful. It gives us a chance to put into place the pieces to help them not be painful. And at future visits, even though we're going to rely on those PDPs at least for a while, we can actually find patients who will be counter-conditioned that they do not, in fact, need that PDP at a later time. What has really been just wonderful about free training is that it helps to give us an understanding of what that FAS experience is, gives us context for reducing it, and it gives us tools to address it. It gives us a chance to give our patients what they need and deserve. We know that this toolbox is going to continue to expand as we have new understanding of how we can help painful patients both with and without FAS. We know that we have nutraceuticals to be used in addition to pharmaceuticals. And one of the things that is a very, very new tool that I feel obligated to mention is Purina's Canine Calming Probiotic. I have now had the opportunity to leverage this tool in about 30 patients, and I realize that 30 is not like 300, but it's certainly a more clinically relevant number than 3. And I can tell you that it is proving itself to be a game changer in my practice, not just for painful patients, but for my patients who have FAS. We also need to remember that we have the option of using a nutraceutical that leverages the alpha casozepine, which is the active ingredient in Zilkine. There are so many of these tools that we can reach for, and one of the beauties of them is they complement one another. And that's Rooney. He lived to be 22. He was my clinic mascot, and he's telling me that it's time to wrap it up. So, a few comments on disassembling this pain management pyramid. So first of all, we want to get the patient comfortable and stable, get them as functional as they can be, get them as strong as they can be, and then start to change only one thing at a time. What I do is I want these patients comfortable at least 1 to 3 months before I start adjusting any medication doses. And I reduce the drug with the greatest potential to cause adverse events, which generally is the nonsteroidal anti-inflammatory drug. And this is where I'll I said earlier, this cannot be done unless truly multimodal patients will in fact have a relapse. So if possible, we want to stop our nonsteroidal, but don't be bashful about using a dose that's not quite 0. Make sure that you're doing your reassessments at regular intervals. I choose 2 to 4 weeks. And if, in fact, I reduce or remove the nonsteroidal and the pain returns, I go to the next higher dose that kept that patient comfortable. These are the things that we just never take away. We don't take away adequate. We don't take away omega-3s. I don't take away UC2 or nutritional joint support. I don't take away that molecule microlectin. And if I've got them using low molecular weight chondroitin with ASU and glucosamine, I keep them on it as well. What I do, though, is gradually increase the time that passes between the times they see me for physical medicine or for reassessments. So I put more and more of that in the client's hands for home activity and therapeutic exercises. And I like to think of long-term PT as doing PT tune-ups. So as we close, what are some of the keys that we need to look for to succeed in this process? Well, first is to create as detailed and personalized a plan as possible, to write everything down, not just for us, but for the client, and in dialogue with the client to create realistic expectations for that pet. It's very important that they understand that you're not going to make a 13-year-old into a 3-year-old. That's just not going to happen. We want to schedule the next reassessment before they leave. So they do not get to leave my hospital until we have the next appointment scheduled. And that means that we are not going to let those patients fall through the cracks. Every time they come to see us, they get a little recitation. We go through a mutual recitation of medicines they're taking, the nutraceuticals they're taking, what are the doses they're giving, what is the feeding that they're giving. We do that at every single visit. You would be surprised how many times someone will fall into a habit and they just don't they haven't read the label lately, and they've forgotten how they're supposed to be giving a medicine. And then we also track their refills, so that we know if we send home a 3-month supply of a medication and they've used it up in 2.5 months, they haven't been dosing properly. The converse is also true. If I send 30 days of medicine and it's been 45 days and they've not got a refill, I know that we have to talk about that. I will just encourage you all to relish the challenges of chronic pain, because these are the most rewarding patients I deal with. My whole healthcare team gets totally jazzed about dealing with these animals, because these are really very rewarding cases, and these are often our most committed clients. As I say thank you, I do want to mention that one of the tools that is becoming of great interest with the change in the Farm Bill at the national level is utilizing CBD for chronic pain in dogs. And we do have one study published now in Frontiers Veterinary Medicine that came out of Cornell. I actually completed a 90-day study here using a different CBD product. We're actually crafting the manuscript right now for publication. Also, we hope in Frontiers Veterinary Medicine. The bottom line is, if you choose to move in the direction of utilizing CBD, it's going to be critical that you're utilizing a product that's been that has been investigated with independent analysis to make certain that there are no contaminants, to make certain that the molecules that are said to be present on the label are actually present, and that the concentration that is on the label is actually what is in the product. This is something that I think is going to be the next big frontier for pain management in veterinary medicine. So thank you all very much. And Christy, I'm going to turn it back to you.
Great. Thank you so much, Dr. Downing. That was amazing. And we have several questions. Let's see how many of them we can get to. The first question was one asking the benefit of Adequan sub-Q versus IM.
So we don't have any white papers yet that show us that we get the exact same pharmacological activity delivering it sub-Q versus IM. But I will tell you that clinically now, with 25 years of experience delivering it sub-Q, I am seeing the same outcomes that I saw when I used it IM. The big advantage being that it doesn't hurt the patient, and this means that we can teach clients to do this at home. I think what we're going to find is the very same phenom that we found with the molecule in the product called Percortin. Many of you will remember that Percortin, when it was first introduced into the marketplace to treat Addisonian patients, was labeled for IM use only. And now we understand that we can and should be using it subcutaneously. I absolutely believe that we're in the same place with Adequan.
Okay, thank you. The next question was one I think that gets tossed around quite a bit lately. What are your thoughts on the usefulness of tramadol?
So actually, it's not about what I think. It's actually, now we can look to Steve Budsberg at Georgia. So Dr. Budsberg and I go way back. We've been involved in multiple pain management programs over the years. And Dr. Steve's opening line at the American College of Veterinary Surgery forum this last year was that as he presented his findings, he hoped that this would put the last nail in the tramadol coffin. And I think that his data certainly have. So if you look at his paper that was published in the JAVMA, you will see that, in fact, tramadol is a useless drug for us to use in dogs or cats as a pain management strategy for different reasons. So in the dog case, the M1 molecule that is the breakdown product that actually affects the receptor is present in the dog for about 30 minutes, making it completely ridiculous to think that it would help us with chronic pain. The problem that we have with cats is that it is so super bitter that it can actually make them completely anorectic. And if that were to happen, then of course we have kind of shot ourselves in the foot. So while there may be some pharmacologic advantage to, let me get rid of this. There may be some pharmacologic efficacy for tramadol in cats. I would never use it in cats because it's already difficult enough for us to medicate cats. But tramadol in dogs, completely useless. It is beyond the pale to me that anyone is still using it, because we are actually, I think, ripping off our clients to provide them with something like that that is a useless tool.
Wow. Okay. I'm calling you after. Another question, we have a couple questions on gabapentin. One of them is, how quickly do you see rebound pain start if gabapentin is abruptly stopped?
That's a great question, and can vary it can vary, but in the human literature, it can happen in 2 to 5 days. And in in the 2 patients that I actually witnessed this in, one dog it was 3 days. The other was closer to 7, but the results were debilitating and very dramatic. But in the human literature, it's actually a pretty quick process, 3 to 5 days. And some people report it happening even within 48 to 72 hours.
So is there a taper that can be used, or is this just part of cessation of gabapentin therapy?
So gabapentin in the face of chronic maladaptive pain is a tool that simply should be used long-term, and in fact may need some escalation over time as osteoarthritis progresses and the pain experience progresses as well. So I just prepare my clients that the animal that has chronic maladaptive pain is probably never going to come off gabapentin at any point. That said, if I'm using it in an acute, so this is one place where it's important to understand that in an acute setting, so for instance, if I have a patient who's having an orthopedic procedure and I'm going to use gabapentin to complement my nonsteroidal and then the physical medicine things like laser and ice therapy and range of motion and other things, that is a situation where I'll use it at I'll use it at a dose for about 2 weeks post-op, and then I will taper. So the 3rd week I'll drop the dose, the 4th week I'll drop the dose, and then we'll stop. But that's in an acute pain setting. In a chronic pain setting, I am rarely going to, I can't remember the last patient I dealt with that I actually removed gabapentin from use for chronic maladaptive pain, primarily from osteoarthritis and multiple joints.
Wow. Another question on gabapentin. How does gabapentin work for FAS, and what is the duration?
So what a great question. I don't have any idea how it works for FAS, other than it really decreases anxiety and takes the edge off. Duration, I create the expectation for my clients that their cat is going to be stoned for approximately 6 to 8 hours total time. Because we know its mechanism of action is in the dorsal horn of the spinal cord. That's for pain. But this whole phenom of using it for relaxation, I don't know that we completely understand the pharmacology of that and the mechanism of that. But the outcome that we see is a cat that is far less anxious to be in my presence, and they're actually impaired. They're stoned. So they are willing to let me at least get close to them, which is a huge improvement for a cat that otherwise would try to tear my eyeballs out.
Okay, then. Good. Because we're against that. And we have one last gabapentin question.
Sure.
Is the combination of gabapentin and amantadine safe to use post-cesarean section and post-surgical insemination where one might want to avoid NSAID use?
Oh, what a great question. So the only issue I would respectfully suggest is that I don't know that we understand how quickly amantadine can have an effect. So gabapentin definitely does have an effect pretty quickly. And in fact, one of the papers on the human side that prompted me to look at using gabapentin in the perioperative period was a study that was done in women who had cesarean section. It's just so funny that you mentioned cesarean in particular. This was a study done in women, and it was a study to look at the use of patient-controlled analgesia, PCA. That's the pump that allows you to push a button and get a little hit of morphine. And what they found was in those women who had gabapentin postoperatively, their use of patient-controlled analgesia, their use of self-delivered morphine was dramatically reduced. So I would respectfully suggest that gabapentin might not be a bad choice at all if we are trying to avoid the use of a nonsteroidal in an acute pain management situation like a cesarean. I cannot speak to the acute effects of antidepressant.
Okay. So moving away from gabapentin, although we got another question about it that I'll maybe come back to if we have time, and going in a completely different direction, have you used CC loops as an adjunct or with physical therapy?
So herein lies the problem of having 1 hour to talk about this stuff. So the answer is yes. I use the targeted pulsed electromagnetic field therapy device called the CC loop quite a bit in my practice. And it does yet a completely different complementary activity on a cellular level to any of the other physical therapy techniques that we have available. We have a really good paper that just came out of the AMC not that long ago looking at using the CC loop in dogs. There's a tremendous amount of data in people. Its approval by the FDA for humans includes things like postoperative pain in mastectomy patients, decrease of edema, increase in the healing of diabetic wounds in people with diabetic neuropathy, peripheral diabetic neuropathy. One of the benefits of the CC loop specifically is the fact that I can send it home so that the client has something tangible to do at home that is going to actually move that patient forward in our quest for comfort in between times that patient sees me. And it's yet another non-pharmacologic way that has been demonstrated in controlled studies to be effective as a strategy for us to complement the other things that we do for these painful patients, equally in cats and dogs.
So we have more questions than we're going to be able to get to. So let's see if we can get through a few more fairly quickly. Thoughts on using Galliprant versus NSAIDs for chronic OA pain?
So I actually consider Galliprant one of the NSAIDs. I know that it works by a novel pathway looking at a completely different prostaglandin than the non-steroidal, the traditional non-steroidals, but it actually has the same side effect profile as the other non-steroidals. So GI signs are the one piece that we have to watch for. I really have no preferences among the anti-inflammatory pain relievers. So Galliprant is one of the drugs I have on my shelf. I find that if I can reach the same effect, one of the advantages to titrating the dose of a non-steroidal, whether we're talking about a traditional non-steroidal or Grapiprant, the active ingredient in Galliprant, is that by titrating the non-steroidal down, we actually have a tool available to us should that chronically painful patient have an acute pain episode. So let me give you a tangible example. If I have a chronic pain patient and I've titrated the non-steroidal down, and now that patient develops a tooth-root abscess that necessitates a dental intervention, now I have available to me a potent non-steroidal anti-inflammatory drug that I can use postoperatively in that patient. Whereas if that patient were already on a max dose of a non-steroidal and I make an acute intervention, whether it's a dentistry or a tumor removal or an orthopedic procedure, I don't really have anywhere to go for managing that patient's acute inflammatory pain superimposed on their chronic maladaptive pain. But if I have titrated the non-steroidal dose down, I actually have that non-steroidal available to use in an acute pain and acute inflammation setting, even though that patient has chronic maladaptive pain on board already. I hope that makes sense to everyone.
It does. I'm afraid, everyone, that is all we have time for. For your questions, but thank you so much for being here and for asking so many really great questions. Remember that for those of you who are attending this webinar live, not those of you who are watching it in the future as a recording, I will be sending out the CE email in a few minutes. And remember to email me at fearfreepets@gmail.com if you don't receive it tonight. The CE survey is only open until Friday, so please just take it right away. There's hardly any questions. It's very easy, but you can't get your CE without taking that survey. And once it closes on Friday, we will not be able to process any more CE applications. I really want to thank you so much, Dr. Downing, for being with us. And also, again, thank Veta Keenal for making this presentation possible. And thanks to everybody who is here tonight. Take care. Bye-bye.
Thank you.